Now, I would like to introduce Professor Mahmoud Salah. He's going to talk about recanalization of chronic iliocaval venous occlusion challenge cases.
Thank you very much. I'm going to talk about iliocaval venous angioplasty cases and stent selection. I have no disclosure. Of course, we should keep in mind the difference between the artery and the vein about physiological angles. The movement of the veins are different from the arteries. Chronic venous outflow occlusion, non-thrombotic iliac vein lesion, or both thrombotic. And it's very important to have an idea about the degree and length of the lesion and the collaterals. In recent era of endovascular, of course, angioplasty and stenting is now used in the patency, maintain patency in the iliofemoral venous outflow. Of course, difficult recanalization can be due to outflow resistance, fibrosis, or thrombotic or fibrotic transformation. Which patient would benefit from stenting? Of course, the patient who is suffering from signs and symptoms, CYP3, 4, 5, 6, those affecting quality of life, significant lesion, and the contraindications not to interfere for such patients with severely impaired inflow with or DVT in the past 10 months where spontaneous recanalization is still expected. If the patient is asymptomatic or he's having any contraindication to therapeutic anticoagulation, so it's not wise to interfere for endovascular recanalization. The success of endovascular recanalization depends on the inflow, conduit, and outflow. The inflow, of course, depends about the correct landing zone, the quality of the inflow vessels, the conduit, of course, the pre-dilatation, the stenting selection, and the post-dilatation, and the outflow depends on the again, the landing zone and the confluence of the iliac veins. Why venous stents are different? The nature of the disease is different. Of course, atherosclerotic in arteries, it's thrombotic in veins. So we need radial resistance force higher in the venous stent. For the vessel diameter, of course, the veins are wider, so we need wide range of diameters. The vessel's flexion, the veins are tortuous, so we need high flexibility of the stent. The age is different. Of course, this is 65 and above for the arterial, while 30s in the venous, so we need something long-term durability. And the flow dynamics is different also. This is high flow in the vessel, in the arterial, and low flow in the venous. Is the venous stent new? Actually, it's not. We used to use the venous stents long time ago where the wall stent was used, but the results were not perfect. Why we needed change? Because the stent, the whole stent was tricky in deployment. Extension to the IVC usually blocks the other side, a high tendency to shortening and migration, and the patency rate in the best hands were maximum 70%. These are some studies were done, and the expectations of the venous stent, of course, if this is the arterial stent, we need this to be for the venous stent. These are, you can see the kink in the arterial stent, while the kink in the dedicated venous stents, as you see, there is no angulation. So we have closed cell and open cell in the venous stents. The closed cell is more crush resistance, than the open cell, while the flexibility is better in the open cell than the closed cell. Again, these are the dedicated venous stents. We have many products, and a lot of engineering investment was done. Many companies have this dedicated venous stents. The advantage of the dedicated venous stents, they have precise deployment, they have balance between the radial force and the flexibility, wide range of diameters and lengths, radio opacity, and do not need to cover the contralateral limb. These are the venous stents we have in the market. Still, Boston have the wall stent. We have Silver Vena, we have Sinus Obliquus, we have Abri, we have Optimed, Veniti, and Vici, and Venovo, and the Blue Flow. These are the different types of the venous stents we just mentioned. These are the Venovo from Bard. This is the Abri. They have different type and different delivery system. This is the Abri again, and this is the Sinus Venous and Sinus Obliquus from Optimed. This is the Vici, the Blue Flow. So different venous stents for different location. For the IVC and the common iliac vein, we need high radial force, while in the external iliac vein we need balance between the radial force and the flexibility, and the common femoral vein we need the flexibility, and the kink resistance is much more needed. There is no one stent for all lesions. The story below the ligament and the stent fracture, all the problems of the venous stents, most probably they comes below the ligament. The sizing, of course, is different. IVC, we are speaking about more than 20, common iliac more than 16, external 14, and the common femoral 12. And using small stent is catastrophe, because this will be the beginning of long cascade of problems. The design, again, the open cell and the closed cell will not repeat again. These are Venovo study was done. This is the longest, was about 36 months, and the patency rate was about 79%. And this study was about the Abri, was for 24%, and the patency rate was 86%. And for the sinus from Optimed, they had only 12 months. The study was 12 months, and the patency rate was 91%. These are the published data. There is no difference in overall patency above the ligament. I can skip all this. These are some cases. And what if the venous stent failed? If the venous stent failed, we should check if it's early or late. The first option, to stop, consider the reason for stenting in the first place, what caused the stent to fail, and what are we trying to achieve. In conclusion, no real data suggests one stent over the other. There is no perfect venous stent for the whole system. The main issue is the inflow. Good inflow and common femoral vein is normal. All stents performs well. Regarding the design, open cell and braided stents best under the ligament. However, all performs well above the ligament. Understanding the design and details of every stent and where to put each stent and selection of the patient are the keys of success. Thank you very much.